Good evening. I'm Dr. Mohammed Marzouk, and it's my pleasure to welcome you to the second round of our webinar series. Tonight, our special guest will be Professor Puringer. For our attendees who don't know Professor Puringer yet, I will say that Professor Puringer is not only an anesthesiologist. He held several academic positions, and now he is chairman at the Department of Anesthesiology and Intensive Care Medicine at Reutlingen in Germany. Tonight, Professor Puringer will share with us his large experience with the modern anesthetist. It will be 1 hour talk followed by Q&A session. Please welcome with me Professor Puringer, and the floor is yours.
Well, thank you very much for your kind introduction and for the possibility to give this webinar to you about modern volatile anesthetics in anesthesia. Sorry, this is the wrong one. This is the wrong presentation. Sorry. Oops, I'm sorry. There is a No?
Not yet, Professor Puringer, but I will say...
I'm very sorry, but somehow, yeah, this is what we need. Sorry for this technical problem. You see it on the full screen now?
Yes.
Yeah, okay. So I will be talking about inhaled anesthesia in demanding patients, how and why to perform it. I'm based in the southwest of Germany, in the area of Stuttgart, and Reutlingen at the University of Tübingen is around 40 kilometers south of Stuttgart. And you all know the famous brands from around this area. This is like Mercedes-Benz, this is Porsche, this is Hugo Boss, and this is Bosch Electronics. But also, which is very famous in this area, around 100 kilometers south is Tuttlingen, with the famous medical brands like Storz, like Esculap, and Tuttlingen is kind of the world capital of medical technology. If we are looking in this area, especially when you mention and you think about Mercedes or Porsche, this car industry is very, very famous, and we have some very, very beautiful museums here with all the old cars also represented there. So whenever you come to Stuttgart, you have to go for a visit there as well to see all those famous cars located there. Coming back to my hospital, we do all medical disciplines here except cardiac surgery and except transplant surgery. We are academic hospital of the University of Tübingen, and we provide around 15 to 16,000 anesthesias a year. We run as a department also intensive care, and we do a lot of workshops, and we provide a lot of teaching things for colleagues from around the world in terms of airway management, also in terms of anesthesia techniques. What is kind of specific for Germany is that anesthesia also provides pre-hospital emergency service. So we have 5 emergency cars covered with anesthetists on board to do pre-hospital emergency service as well. And we do preceptorships and courses for anesthesia techniques. And these are all colleagues from around the world participating on those courses in my department. So whenever anyone is interested to join one of those courses, you are always welcome. When we look about modern anesthesias, the question is always, what do we need? And we want predictable drugs. And what do I mean by that? It's that we want fast onset, we want fast offset, and we want a consistent duration. This is important, not kind of huge changes in the duration of the action of those drugs. And low or no metabolism is an advantage. But when we talk about reliable drugs, it also means that it should be unaffected by age, body composition, gender, or organ dysfunctions. And we all know that we have a lot of population who is impaired by organ dysfunction. So it is really important that those demanding patients receive the best drugs, not to interfere with already impaired organ functions. And of course, for me as head of department and medical director of the hospital, patient safety is of utmost importance. And this is why I do not want any impairment of vital functions perioperatively, especially in terms of protecting airway reflexes, ventilation, or cognitive function postoperatively. These are data already from 1991, so pretty old. But nevertheless, the importance is tremendous in those days as well. And I'm really always a little bit disappointed when I realize that how dramatically those important data from almost 30 years ago are still ignored. And Parr and his colleagues, they were looking about respiratory complications following anesthesia compared to the state of awakeness at the end of anesthesia. And group 1, as you can see here, are those patients who were fully awake of anesthesia. And if you see, no matter if you're young, which is the pink color, middle age, which is the yellow one, and green is the elderly with an age above 70, the incidence, if you're fully awake at the end of anesthesia, is around 1% or even less in the younger ones for respiratory complications. But if patients, and this is shown with the second columns here, were only responsive to verbal commands, so they were kind of awake, but they were only upon verbal stimulation, commands. The incidence in the elderly dramatically increased 6 times to 6%. Even the middle agers by another 5 times, up to 3.5%. And the younger ones even increased respiratory complications. And if we skip over to physical stimulation, where the elderly didn't have a huge increase in complications anymore, but the mid-agers dramatically increased respiratory complications, and even the younger ones. But if you go to that group where people were unresponsive at the end of anesthesia, you see that there was a dramatic increase again in the elderly. So when people tell me, I want that my patients are fully calm at the end of anesthesia, this is not good. This is not good. This is not good for the patients, because this causes respiratory complications in the elderly, even in the mid-ages, and it's also dramatically increasing to being compared to being fully awake in the younger people. So this is why we have to be aware of the fact that people have to be awake, brilliantly awake at the end of anesthesia. Otherwise, they are in a reasonable danger of getting respiratory complications postoperatively. Well, if we look at the chemistry of desflurane compared to isoflurane, you see the molecule is kind of the same, except one change, that the chlorine atom, which is replaced from the isoflurane atom into a fluorine atom, and this changes the whole pharmacodynamics and the whole pharmacokinetics of the structure. Kind of making out of an old East German Trabi a new Mercedes sports car. So one molecule changes the whole pharmacokinetics of the drug. And the kinetics is that you have a fast onset because it results in a lower solubility. You see within 2 minutes, you have 80% saturation in the central compartment. whereas for sevoflurane, the 80% saturation takes around 20 minutes. Desflurane is almost as fast as nitrous oxide, which is stated as laughing gas here, written in German. If we look at the elimination, and this is important for us when we look back to the data from PAR, that people have to be fully awake at the end of anesthesia, no matter how long you're applying desflurane, people are waking up very, very fast. Because of the low solubility, you get rid of the drug pretty immediately. There is a low context sensitive washout. If we look at the blood gas and the fat blood partition coefficient, the lower the number is, the faster the transfer is from one structure to the other. And you see from blood back into the alveoli, so at the final step of elimination, you can see 0.42 for desflurane, 0.65, 50% higher for sevoflurane, and 3 times higher for isoflurane. But very interestingly, when we look about the elimination from fat into blood, you see 29 for desflurane, almost twice as high for sevoflurane. And interestingly, for isoflurane, this elimination is faster from fat into blood compared to sevoflurane. So there is a higher solubility in fatty tissue for sevoflurane compared to isoflurane. And the lower solubility in all the compartments is evident for desflurane. And in this column, you can see that also from brain to blood, the lowest partition coefficient is for desflurane, and again, lower for isoflurane compared to sevoflurane. This is very interesting that the last step, isoflurane, is slower than sevoflurane. In all the other steps, isoflurane is even faster than sevo, but desflurane is always by far faster than all the other volatile anesthetics. If you look at metabolism, there is no metabolism for desflurane. There is the highest metabolism for halothane. We all know about halothane hepatitis. This was due to the metabolites. We all know about the problems with compound A on sevoflurane, which actually someone might say, is metabolism important? Well, if we look, and I will come back to that technique at the very end, in terms of low flow or metabolic flow, it is important, because during metabolic flow, when you recircle the gas several times or for hours inside the anesthesia system to save money, because you don't waste any anesthetic gas, it's beneficial to have no metabolites or compounds. The MAC values, these are things you all know from your daily clinical practice. For desflurane is 6%, for sevoflurane it's around 2%, and for isoflurane it's around 1%. MAC is age-related. If we look on desflurane, we can see that neonates have a MAC of around 10% in 100% oxygen. In children, it's around 8%. In the normal population, it's around 6%. And in the elderly, it's around 5%. I do not use nitrous oxide for more than 10 years in my department, and there is no need to use nitrous oxide for desflurane administration at all. Very important is that MAC is influenced by adjuvants like morphines or opioids. And so in adult patients where the MAC is around 6%, the MAC in the presence of 3 mg per kilogram of fentanyl, that goes down to around 3.2. So there is a dramatic drop in MAC. Nevertheless, we know that half of the patients are still reacting to a surgical stimulus. We don't want to be on that side of the road. This means we have to add another 50% of that value. And if we consider 3.2% as the MAC value, the half of it is 1.6, 3.6 and 3.2 and 1.6 is 4.8. So the end tidal target should be 5%, and I will come back to that number later as well. Well, the topic of this presentation is the use of volatile anesthetics in demanding patients. And this is why I will have a look especially on morbidly obese patients, on elderly patients, on day case surgery, laryngeal mask, and smokers and things like that. And also in cardiac impaired patients to give you some data on those patients. Well, the incidence of morbidly obese patients is dramatically increasing, but the problem is always the longer recovery, the accumulation of anesthetics. I was talking already about the partition coefficient, so about how fast from one compartment a soluble gas is released. And we all know about the airway disorders of these kind of people, like the obstructive sleep apnea, the risk for hypoxia, and the risk for aspiration. So those are really, really important factors in terms of patient safety. Well, I just Googled a few days ago the incidence of obesity, and I was really astonished that number 1, 2, and 3 is from the South Sea. But can you imagine that 50% on the Cook Islands are obese? But nevertheless, Qatar on number 7, 42% of their population is obese, is considered obese. Kuwait, 42.3. United Arab Emirates, number 11 in the world, 37.2% of the population is considered obese. Saudi Arabia, 17th in that list, 34.7. US, 33.7. Lebanon, 31.9. Number 32, UK, 28. So 1/3 of the population. Germany, 20%. So 1/5 of the population. And Austria, which is my home country, 18.4. Well, you know, we have to climb the mountains. This is why we burn probably a little bit more. Well, beside those jokes, I mean, we have to consider that this is an important part of our population we are dealing with, and this is an important part of patients we have to work on our daily basis. And it's not a problem far away, it's a problem in our hospitals. And that's why we really have to focus on these kind of patients to provide best medical care for them. Well, if we look about wash-in curves in obese patients and in non-obese patients, you see for desflurane there is not a big difference. If we look about the washout obese compared to non-obese patients, again, there is not a big difference. This is due to the low solubility of the gas, and this is the dramatic advantage of desflurane. The low solubility means it's hard to get the drug in. This is why we need high concentrations. But at the end, you can see around 80% of desflurane is eliminated within 1 minute in the washout situation only. Within 1 minute, you are releasing the patient, the obese patients and the non-obese patient, about 80% of the administered drug. In comparison, the washout of desflurane to sevoflurane, there is a highly significant difference. Again, 80% of desflurane in obese patients is washed out within 1 minute only, whereas it takes more than 5 minutes for sevoflurane. The reason and the answer is pretty easy. Higher solubility means higher binding and less release. And this is why there is a slower washout for sevoflurane. Of course, there is a difference in wash-in as well, but this is clinically irrelevant since we induce our patients usually with IV drugs. Let's look at the elimination times. And if we look, this is a study done by Lacoya on morbidly obese patients. You see, eye-opening between desflurane and sevoflurane is around 4.5 minutes difference. But if we look about more quality-related data, you see like stating name, this difference initially from eye-opening from 4.5 minutes extends already to 7 minutes. And if we look one step further, stating date of birth, which even requests more cognitive function and a better status of awakeness, means 14 minutes compared to 24 minutes. So this is already 10 minutes. 4 minutes extend to 7 minutes and then to 10 minutes. And this is really what is important, that the quality of recovery, once you wash out Suprane, people brilliantly are awake and very, very predictably. In another study by Strom et al., also on morbidly obese patients, the difference in time to eye opening was like 9 minutes. The time to hand squeeze extended also to 9 minutes. Yeah. Time to tracheal extubation, difference, 11 minutes. Yeah. Time to stating name, 14 minutes. So the differences are getting bigger and bigger. And this is just due to the fact the lower solubility and the fast washout of Suprane is not in a parallel way to sevoflurane, because Sevo has a higher solubility, and therefore this difference is getting bigger and bigger because of the higher solubility of sevoflurane. The low solubility of Suprane is considered significantly faster than any other volatile anesthetic. And even when we compare the situation with propofol, there's a lot of Tiva fans around the world, I know that. But if we look again, and if we look into our clinical practice, we all know that a lot of Tiva patients are waking up pretty nicely, but there is a lot of patients also who are not waking up so fast. And this is, again, it's not as predictable as Suprane. Suprane with the low solubility is pretty predictable. And you see that the difference is time to eye opening around 6 minutes compared Suprane to propofol, and time to stating name, 8 minutes time difference. Yeah. Well, a second group of patients, I think, who are pretty demanding nowadays, because all our populations as society is getting older and older, is that those patients are easily suffering from cognitive impairment. And this is a problem in recovery of the elderly surgical patients. And rapid recovery from prolonged anesthesia can be an advantage for those patients, that they are coming back to normal life pretty fast. Yeah. And again, the low solubility of Suprane is a very beneficial thing for the elderly, because they have a greater proportion of their body mass as fat than younger patients have. So we all know that the proportion of adipose tissue in elderly is increasing, and therefore low solubility is a great advantage. Again, if we compare Suprane with propofol in the time to eye opening, time to extubation, time to finger squeezing, and time to stating name, there is a dramatic advantage for Suprane compared to isoflurane and to propofol. But again, the explanation is pretty easy. Low solubility causes fast elimination, and fast elimination is a direct correlation to better quality recovery data compared to other drugs. If we look on the mean values for extubation, for stating name or stating date of birth, I already showed you in the last columns that Suprane is always faster with ISO or propofol or even Sevo. But what I would like to draw attention here is not the mean values, it's the standard deviation values. You see 3 minutes, 3 minutes, 4 minutes, 5 minutes, yeah. If we compare to propofol, 6, 7, 8, 8, 10. And again, this is predictability, because the low solubility means that there is no variation. And this is what I consider a reliable drug. No matter how long you are using, the elimination time is always fast. We get proper recovery. And again, if we look back to PAR, people are brilliantly awake. And this is what protects from postoperative respiratory complications. Again, there is a lot of smokers around, and smokers are definitely patients we have to deal with in our daily clinical practice. And there is a lot of myth around smokers. And this is why I would like to look into the literature and to talk about the evidence of airway reactions in smokers. I often hear, oh, SIBO is much better than anything else for smokers. But if we look in this publication from McKay, already published in 2006 in Anesthesia and Analgesia, she was looking at patients having more than 5 cigarettes for more than 6 months. Actually, pack years for Desoraine was 21 years, plus minus 25, compared to 12, plus minus 11 for SIBO only. And asthma incidence, or about 24% of the deaths patients were considered to be asthmatic or COPD, compared to 18%. So there was already a statistical significance in the demographics. But nevertheless, there was a blinded observer, and it was about coughing and breath holding and laryngospasm by using those 2 drugs in this heavy smoking population. Yeah. And again, if we look, coughing in the Desoraine group less than in the SIBO group. Breath holding a little bit higher for a Desoraine group, but no laryngospasms occurred. Yeah? And this is what is really interesting, that even though Desoraine is pungent, if you use it in an incorrect way, you can overdose it and you can cause laryngospasm and bronchospasms for Desoraine. But this is when you use it in high concentrations and in a fast wash-in situation only. If you use it appropriately, according to the rule of 24, there is no problem in terms of coughing and laryngospasm. And very interestingly, in this study with smokers, that the incidence of coughing was even higher for SIBO compared to Desflurane. And again, smokers coughed more frequently than non-smokers. Yeah. These are data from the just given publication. Well, again, airway reactions is something which I'm really very, very much interested in, and emergence time in general anesthesia. And we did a huge meta-analysis a couple of years ago, published in the European Journal of Anesthesiology. And we were looking about coughing overall in laryngeal mask airway patients, Desflurane compared to Sevoflurane. And you see there is no difference. Yeah. So using Desflurane for laryngeal mask airway patients is not associated with a higher increase of coughing. When we look about cough at emergence, yeah, there is also no differences, no statistical differences for Desflurane compared to Sevoflurane. About laryngospasm, the same situation. Yeah, that there is no difference in the incidence of laryngospasm during laryngeal mask airway anesthesia. And this is important, that those myths that one drug is superior to another is just not correct if we look in the evidence of meta-analysis. And Desflurane does not have a higher incidence, but it has a lot of benefits, especially in patients who are having a sensitive bronchial system. If you don't have to intubate those patients, you can provide them an LMA, like for vascular surgery. If there is peripheral vascular surgery performed, we in my institution, we are giving them a laryngeal mask airway, and we do Desflurane anesthesia for those patients, because we know that they are brilliantly awake and they are not having the stimulation due to the foreign body of a tube in their trachea. So you can very, very gently anesthetize those patients and providing them a safe return to normal life. Time to eye opening, of course, in benefit in a beneficial situation for Desflurane, but this is due to the lower solubility. And if we're looking at time to respond to commands. Again, a dramatic and highly significant benefit for desflurane. But this is what everyone expected because of the lower solubility. So desflurane and LMA is no problem. According to the rule of 24, there is no increased airway incidence of airway reaction. People can do spontaneous ventilation, but you can also provide mandatory ventilation or mechanical ventilation with continuous positive pressure ventilation. You only achieve airway irritation if you have a too fast wash in. So stay according to the rule of 24. For all those who are not familiar with the rule of 24, I will come back at the end of my presentation to that. I would like to talk a little bit about cardioprotection as well, because cardioprotection, we know already from 1969 when the first papers came up on halothane and then on enflurane, that there is a positive effect. And this is status by De Hert from Belgium, published in the Anesthesiology 2003. And he was looking about troponin values in cardiac unstable patients. And you see there is an increase in troponin levels in TIVA patients with quite a range of variation in several patients. But there is low level changes in desflurane and sevoflurane. So all the volatile anesthetics, this is a group effect, have a beneficial situation in terms of cardioprotection, in preconditioning. This is not where one volatile anesthetic is superior to another. This is all the same. This is the same for halothane, enflurane, and isoflurane. So there is a cardioprotective effect of those drugs. Review article, again, with a meta-analysis clearly showing that there is a benefit of volatile anesthetics in terms of the inotropic situation, the cardiac index, the troponin levels who are dramatically reduced compared to non-volatile anesthetic in coronary artery bypass surgery. And again, what is important, mechanical ventilation postoperatively, highly significant, better for volatile anesthetics and the stay of hospital in the hospital as well. So this is a group effect, and there is no difference when you look into those publications between desflurane and sevoflurane, but there is a huge difference in terms to total intravenous anesthesia. Well, desflurane, as you all know, is a sympathomimetic drug. If you overdose desflurane, you get tachycardia and you get hypertension. So even in higher doses, there is no vasodilative effects. And this is why there is a lot of studies clearly showing that the cardiovascular stability of desflurane is very, very pronounced because there is no vasodilative effects. And this is also important when you have a situation during anesthesia that the blood pressure is decreasing. Do not change the level of anesthesia, because reducing the concentration of desflurane does not have an impact on the vasoconstrictor. If you have a drop of blood pressure during desflurane anesthesia, remain the level of desflurane at 5% end-tidal concentration, but then add, on the one hand side, either fluid or vasoconstrictive drugs if you think that the patient has a stable volume situation. Well, I would like to talk about some clinical and safety effects and benefits of desflurane. And for me, as head of department, these effects are very, very important. And I was talking already about the return of airway reflexes. They are much faster after desflurane compared like to Sevo. This is already a study done by Rachel Ashima McKay, published in Anesthesia Analgesia in 2002. And she was looking at young ASA1 and ASA2 patients undergoing laparoscopic cholecystectomy. And she was looking, once people were properly responding to commands, she forced them that they drink around 20 mils of water. And what did she find? She found that 2 minutes after proper responding to commands, all patients were able to swallow properly water. Whereas only 50% or less than 50% in the SIVO group were able to swallow properly 20 mils of water. Remember, after proper responding to commands. So they were showing the tongue, they were pressing the hand, and even though they were unable to swallow properly. In another study, a couple of years later, published in the British Journal of Anesthesia, she was looking about the impact of increased body mass and anesthetic duration on the return of ever reflexes. And what did she find? Well, this is a different graph, but I would like to show you the distribution. The black dots is the distribution and the return of ever reflex in SIVO patients, and the white triangles is the return of ever reflex in Suprane patients. And you can see on the x-axis, it shows the body mass index of the patients. And you see, no matter how high the body mass index is, the triangles are really in a very, very narrow distribution. Whereas even in a low body mass index, the distribution of the black dots for SIVO return of ever reflexes is dramatically wide and distributed. And just to keep in mind, 1,000 seconds is 17 minutes. If we convert this graph into the graph of the first study, you can see after Suprane anesthesia, even if you have a body mass index of above 30, 96% of the patients are able 2 minutes after proper responding to commands to drink 20 mils of water. And for those tiny little group who was unable, it just takes another 4 minutes that everyone is able to swallow to protect the airway. If you have a body mass index of above 30, less than 20% are able to swallow properly. And it takes up to 35 minutes that they can swallow properly. And we all know in the early postoperative phase, regurgitation and aspiration is a problem, maybe a problem, especially in laparoscopic surgery, in obese patients, in elderly patients. And therefore, increasing patient safety by using the right drug is of utmost importance. If we look at anesthesia duration, again, the distribution of the white triangles is very narrow, whereas for SIVO, it's pretty distributed. And as you can see, no matter how long you apply Suprane, the return of ever reflex is very, very predictable. I would also talk about cognitive recovery, and I would like to talk about gas exchange patterns, because this is also important in elderly patients, in obese patients. We all know that obese patients are suffering of obstructive sleep apnea, and therefore it is important about the changes in gas exchange. And in this study undergoing craniotomy for neurosurgical procedures, you can see in the SIVO group, 15 minutes after extubation, 30 minutes after extubation, and 45 minutes after extubation, there was a drop in the pH values. And this correlated with an increase of CO2. So there was impaired ventilation in the SIVO group, whereas there were no changes in the Suprane group. So there is, again, due to the slower recovery, there is a drop in pH values for the SIVO patients, accordingly to an increase of carbon dioxide. So ventilation was impaired. We all know that, especially in neurosurgical patients, we should keep the level of CO2 stable because it alters cerebral blood flow. And if we look about the awake time, 19 minutes to be fully awake to a region Aldrich of above 9 compared to 39 minutes in the SIVO group. So one might say, does this really make a difference? Is this important? Well, probably not for an anesthetist, but after neurosurgical intervention, it is important for the neurosurgeon to evaluate whether the patient can move all the limbs, whether the patient can feel everything. Because if this is not happening, probably recurrent bleeding occurs. And to figure out recurrent bleeding 20 minutes earlier means that this may have an impact for the future life of the patient. So therefore, it is of an utmost importance that people are properly awakening and people are really, really brilliantly awake at the end of anesthesia. And this happens due to the lower solubility. Again, if we look at the cognitive status postoperatively, the blue cars and the blue lines are representing desflurane compared to the yellow of SIVO. You see there is no cognitive impairment for desflurane patient. And this is due to the lower solubility, which is really, really very, very nicely shown in this study by Bilotta et al. I would also like to draw attention to early postoperative lung function, because this is also something that this might be important for overweight patients. And in this study, Martin Soremba from Germany, published in the Anesthesia Analgesia in 2011 already, he showed that after TIVA, immediately after surgery, half an hour after surgery, 2 hours after surgery, and even 24 hours after surgery, there was a significant lower saturation value in the patients compared to baseline, compared to preoperatively, and compared to desflurane anesthesia. So the question is, why is postoperative lung function less effective in TIVA compared to desflurane? And so he did a lot of lung functional testings, like FVC, like FEV1, like flow measurements. And you see at every single time point, every single lung functional testing was highly significant better in patients after desflurane compared to TIVA. So the question is actually, why does it happen? Why are patients much better able to provide those lung functional testings after desflurane? Well, due to the lower solubility, they are better awake. But again, when they are extubated, they have to be pretty awake. The other thing is that already a couple of years ago, Eastwood showed there is an effect of propofol in small doses who are not really providing unconsciousness, that there is a collapsibility of the upper airway. And he also did the measurement at the genioglossus muscle to really show the effect on the genioglossus muscle of TIVA and not of muscle relaxants. So there is an impact on these measurements. And he was increasing propofol doses and he was looking at flow measurements. So with increasing propofol doses, there was an increased airway collapsibility because it impaired the contractility and the effect of the genioglossus muscle. And you can see with the maximum inspiratory flow, the higher the concentration of propofol was administered to those awake patients, you see, the lower the maximum inspiratory flow resulted. So the collapsibility of the upper airway caused the reduction of the flow. And Eastwood was able to show that he had to increase the critical pressure to keep the airway open. So the collapsibility of propofol due to the effect on the genioid muscle showed that there was a decrease in maximum inspiratory flow. And this is like when this area shown with the red arrows is collapsing. The tongue is falling back and therefore the maximum inspiratory flow is going down. Besides the effect that there is some effects on the flow because of the collapsibility, there is also the ventilatory response to hypoxia. And this is influenced of subanesthetic doses of desflurane and other volatile anesthetics. And we can see that at low dose, the halogenated anesthetic agents like halothane, isoflurane, and enflurane depress the ventilatory response to isocapnic hypoxia in humans. And desflurane does not. It does not have an effect on that. So again, even, and this is very important, at subanesthetic doses, this is representing the post-anesthetic phase. When people are awake, subanesthetic phase, yeah, but still they are not proper responding to hypoxemia. And you can see that almost 100% reaction on desflurane, whereas dramatic reduction to SIBO, enflurane, isoflurane, and halothane. So this is taken from Miller's textbook of anesthesia. But in another study by Dahan, again, looking about the acute hypoxic response, you can see there is no impairment, no depression of the acute hypoxic response, yeah, in desflurane patients. And so the whole system about ventilation, about airway reflexes, about ventilation and hypoxic response dramatically shows the beneficial effect in terms of safety of desflurane towards our patients. This is a very interesting study. I would just like to focus on a little bit because it's about patients undergoing short gynecological day case surgery, yeah, with spontaneous respiration. And the question is, which drug, probably desflurane or sevoflurane, is more beneficial for them? So the anesthesia time, as shown in this red circle, yeah, was only 18 minutes, yeah, and people were anesthetized according to the golden rule of 24. So there were no incidences of laryngospasm and bronchospasm. The wake-up time was much faster for desflurane patients, which of course was to expect. But for me, even more important was that 2 days later, Dr. Mahmoud called all the patients and she asked about the quality of life the day after surgery. And as I mentioned, 18 minutes anesthesia time only, 18 minutes. And the day after, 90% of desflurane patients felt that they had full quality of life, full activity, whereas only 50% in the SIBO group. And again, so we can see subanesthetic doses which are still remaining inside the body of the patient are having an effect in terms of activity and quality of life. Well, I also would like to focus on economical considerations. We all know that labor, human costs is the highest cost in the hospital. In our hospital, human resources take around 75% of all our costs. Drug costs is only 3%. The rest is technical devices and things like heating or cooling and all those things. So 75%, 3/4 of our costs in the hospital is due to people. And therefore we should not think about the cost of devices or of costs of drugs. We have to look at the cost of the processes. Yeah, and if we look about the meta-analysis comparing extubation times, and I mean, if patients are 5 minutes or 7 minutes earlier extubated in one group compared to the other, this really results in reduced costs. And in this meta-analysis containing 32,700 cases, yeah, it was clearly shown that around extubation time, 20 to 25% was reduced by using desflurane. And the variability was reduced by 21%. Again, reduced variability is predictability, and this is due to the lower solubility. And 25% reduction in the mean extubation time, highly significant compared to sevoflurane. Those things together translate to a 75% reduction in the incidence of prolonged extubation. So 75% less prolonged extubation times. And this is the predictability I want from a drug, that no matter what the patient is, I want to have a predictable and reliable recovery and extubation time. And in this graph, you can clearly see the longer it takes for the extubation for SIBO patients, the bigger the difference gets. So if it takes 19 minutes for an extubation after SIBO, you would be 40% faster. That means around 8 minutes faster with desflurane. Again, the same situation comparing desflurane and propofol. Yeah, this is a meta-analysis, again, containing 26 studies, more than 800 patients. And you see extubation time, 21% beneficial towards desflurane, variability, 26%, time following commands, 23% faster, variability to time to follow commands, 39% beneficial towards desflurane. Highly significant. But this is very clear. Low solubility means fast elimination, and propofol and Tiva has a problem on that side. But economical considerations do not mean drug costs only, but drug costs can be saved as well by using metabolic flow. And if you are using desflurane with a fresh gas flow of 2 liters, it means that you have an hourly consumption of 42 milliliters. And if we consider that the bottle of desflurane contains of 240 milliliters, this means after 6 hours anesthesia time, a whole bottle is gone. If you reduce the flow, the fresh gas flow during anesthesia to 1 liter only, the hourly consumption is 21 milliliters. That means the same bottle lasts already for 12 hours. So if you reduce the flow to 2.5 liter fresh gas flow, the hourly consumption is 10.5 milliliters only, which means one bottle lasts already for 24 hours of anesthesia. And like we do it in my department, we are going down to metabolic flow, 200 milliliters of pure oxygen only. The hourly consumption is 4 milliliters. So the whole bottle lasts already for 60 hours. Yeah. And this is what saves money as well. So the flow is the trigger in terms of anesthetic costs. And no matter which gas you are using, but you can't use other gases in that low flow situation because of their metabolites. And this is the advantage of having no metabolites with desflurane, that you can reduce the flow, and when you recircle the gas, there is no problem of any toxic metabolites. So the less flow you're applying for your patients, the less costs you are producing for your hospital. How to use desflurane in a safe way, and I'll just show you how we do it. We call it the Reutlingen principle, the wash-in of desflurane, the rule of 24. The rule of 24 is just the calculation of the concentration on the vapor times the fresh gas flow for the wash-in situation. And if you apply 12% on the vapor and 2 liters fresh gas flow, it takes you around 2 to 2.5 minutes to get an end-tidal concentration of 5%, which is the target. You can also apply 8 and 3, 6 and 4, and results in the same situation. Why? We have to consider that a normal anesthesia machine usually contains of 6 liters volume. So that means when I have a fresh gas flow of 2 liters initially, I replace in the first minute 1/3 of the content of the anesthesia machine, and 1/3 of 12 is 4. If I go 8 and 3, with 8 and 3 liters, I replace half of it. Half of 8 is also 4. So no matter if you're using this or the third variation, it results in the same effect, that we are targeting an end-tidal concentration of 5%. Why? As I told you initially on the MAC values, the MAC value in the presence of opioids like fentanyl, sufentanil, or remifentanil is going down from 6 to 3.2. And if we add another 50% of that 3.2 Mach, we are around 4.8 to 5%. And this is what I'm targeting and what we are targeting as the optimum end tidal concentration for our patients. And once we are there at 5% end tidal for maintenance, we are reducing the fresh gas flow. And just to give you kind of a target, when you're reducing the fresh gas flow to 200 or 300 milliliters only, keep the vapor at 12 to maintain the level of end tidal concentration at 5%. If you have a higher fresh gas flow, you can reduce the vapor to 8% when you are on a range of 500 to 800. And if you have a fresh gas flow of around 1 liter, which I think is not important or not necessary, you keep the vapor at 6. We all know the oxygen consumption of a patient per minute is 3 milliliters per kilogram. So if you have 100 kilo person, he consumes 300 milliliters of pure oxygen. And this is what I'm applying into the machine. There is no need to add something else. If you have a swimming pool in your garden, you would not change half of the water every day or every week. You would replace on a Sunday or on a Friday with a small piece the water which has been evaporated by the sun. And this is what metabolic flow means, that you just replace the amount of oxygen the patient is taking out. And this is why we are going down during anesthesia on 200 milliliters of pure oxygen to have metabolic flow. The flow is just according to the metabolism of the patient. So our Reutlingen technique of anesthesia is that we usually start with fentanyl. We wait until the patient is dizzy. During that time, we already provide proper pre-oxygenation. Propofol is inducing anesthesia then. We wait for unconsciousness. There is no ventilation with any volatile anesthetic then. We just try to ventilate with pure oxygen. We place the LMA or we place the endotracheal tube. If we intubate, of course, we use rocuronium or for relaxation. And once the airway is set, we start with the induction of desflurane. So there is no contamination of the surrounding by providing volatile anesthesia on the mask. And after the induction, 12% at the vapor starts with 2 liter. And once we achieve 5% end tidally, we reduce to low flow or metabolic flow. So the conclusion of this presentation is the anesthesia challenges are changing. We ERAS program and all these things. So we have to shift to modern drugs and to optimize our techniques. We have to maintain the high patient load. We have to optimize OR turnover. We are dealing with a lot of very sensitive patient groups. And desflurane provides faster, more predictable recovery. It provides complete recovery. This is important. I think this is what I showed you during this presentation. Even in sensitive group of patients, especially in sensitive group of patients, they really provide complete recovery, that people are recovered to protect themselves, that the hypoxia is prevented, that they breathe and ventilate properly, and they protect their airway. So these are the things which are important, because in the early postoperative phase, hypoxemia is the biggest problem to harm our patients. And as I showed, desflurane is a cost-effective option because you can reduce the flow. So only the best for our patients, but the correct use. Use it according to the rule of 24. 2 minutes on-site flow, target for an end tidal concentration of around 5%. There is no nitrous oxide needed. You can induce with an air-oxygen mixture. This is what we do, and then we reduce the flow. And with that and the landscape of the Black Forest, I would like to thank you for your kind attention.
Thank you, Professor Poringer, for your presentations. Very interesting, as usual. And tonight we know better why you are using daily desflurane. So we have several questions. I will start with the simple one. How did Suprane changes the anesthesia practice in your organization, Professor Poringer?
I didn't get the question. I'm sorry.
About the use of desflurane in your daily practice. How there is a change between sevoflurane before and nowadays with the desflurane?
Well, we changed in my department. We changed already 20 years ago to desflurane. The thing is, the low solubility, and this is what you really figure out when you use the drug on a daily basis. And according to the rule of 24, that it's very predictable. So you don't have those days and patients where you want to extubate and the patient is not waking up. Yeah, and this is the predictability everyone who finds out about desflurane. The thing is, when desflurane was introduced into the market in the mid-90s of the last century, the problem was that Baxter told us that we should increase, in incremental doses. Yeah, so it was pretty difficult to apply because we were intubating the patient, and then we every 30 seconds we should turn the vapor by 1 or 2% up to get to the end tidal concentration. And just by seeing that you run sometimes into trouble doing this kind of inconvenient way of apply desflurane, a lot of people stepped back and said it's much easier for you to use sevoflurane. But when we figured out with the rule of 24, and as I said, why 24? Because with this kind of amount of 24, no side effects are showing up. Yeah, there is no tachycardia, there is no laryngospasm, there is no bronchospasm. And the philosophy is, I just have the vapor and I have the flow. And if the flow is 1/3 of the content of the whole anesthesia machine, I cannot overdose it in a fast way. And this is when we found out that it's very convenient to use the drug. It's a safe drug, and it's a reliable drug and a predictable drug. And this is how we use it. And every resident who is working in my department for 1 month is familiar with the drug because they don't see any side effects. And this is why I always invite people, come to my department, have a look for a week how we do it. And then you are really confident that this is a very safe drug because we use it in the neonates, we use it in pediatrics, we use it with LMA, we use it with smokers, we use it 95% of all our operations are done with desflurane. We do not do desflurane in patients with craniotomies when they have an increased cerebral pressure because this is a no-go, and we cannot do in babies a volatile induction. Yeah, you cannot do it because then you get airway reaction. So you have to do in those neonates or infants, when you do a volatile induction with gas, you have to do it with Sevo. But when the airway is set, we skip over again to desflurane.
Thank you very much, Professor Poringer. So, according to several clinical studies, there is a significant difference between desflurane versus sevoflurane when it comes to recovery. How do you define the high quality of recovery when with the use of desflurane?
Well, I think I already gave the answer. The low solubility. This is the thing. This is the chemical structure, the low solubility that desflurane is not taken up heavily, like there is no high receptor binding of the drug inside the tissues. There is no bind. This is the low solubility. And this is like, if you have a water-resistant surface and you pull some water there, it just drops off. Yeah, of course, it makes it wet, but it's gone again fast. Yeah, and this is kind of the same effect. The low solubility is responsible for the fast elimination, and the fast elimination is just what makes us recovery fast again.
Yeah, thank you very much. So we all understand the cardioprotective effect, which is a group effect or class effect with desflurane and SIVO and other gases. What about the brain protection, Professor Pollinger, with desflurane?
It's a group effect. It's the same for all gases. Yeah, there is no advantage in the cerebral protection in terms of halothane, enflurane, isoflurane, or sevoflurane. There is no difference. And this is what we have to say. Again, for all other organ systems as well, the whole discussion about protection, I really found that discussion pretty ridiculous. I always keep saying this discussion was initiated because they couldn't show any pharmacodynamic benefits for sevoflurane. So they were trying to show us any protective effects. But we have to, if we look into the literature, we can see the same effects are already shown for halothane in the 1960s and for enflurane in the 70s. And so this is a group effect. This is the group effect, and that's what it's all about. Yeah. So there is no one is better than the other one. We can clearly see, like if we look about the preconditioning effects, in cardiac surgery, that if we precondition with desflurane or with SIVO or with halothane or isoflurane, and then we clamp and we reopen, and it is the same reduced myocardial area compared to TIVA or something like that. But this is a group effect, and this is again very, very clearly shown in several studies.
Thank you. And if we move now to another specific patient group, which is pediatric with children, is there any recommendation with the use of desflurane for those patients?
Yes, we in my department we are doing a lot of pediatric cases as well. The thing is, as I just mentioned, we usually do an IV induction in these kids if we have an IV excess, and we try to get an IV excess. We using lignocaine plasters, EMLA plasters, so that we can set an IV access, and then we induce with propofol, with fentanyl. We set the airway. And then we start according to the rule of 24 again with desflurane. If we have a volatile induction, we need to have a volatile induction because we don't have an IV access. We do a volatile induction with the single breath technique of sevoflurane. We ventilate the patient down, and then we intubate or we put an LMA in. And once the airway is set, we change to desflurane. Why? Because we know that the postoperative agitation provided after sevoflurane can be abolished and diminished when you change to desflurane. So desflurane does not provide postoperative agitation in pediatric cases. And this is what we like at the end of anesthesia, that when we bring the kids to the PACU, that they are calm, that they are not agitated. And we all know about the problem when we have those agitated kids in the PACU, and then you need some propofol to calm them down again. Some of them stop breathing, and then you get in that kind of circulus viciosus with the problems. And this is why we clearly say there is an indication for SIVO, but just for volatile induction by the mask. If we have an IV access, we just do it on desflurane. Stick on the rule of 24. Kids need a little bit of higher MAC value. So our target is end tidal is 6%. In kids below 1 year, we even go up to 7.5%. But if you stay in that range, there is no airway irritation, and it's very stable. And again, the incidence of postoperative agitation is 0, like with propofol or like with isoflurane. I don't hear you. Microphone.
Yeah, sorry. One of our attendees is asking about side effects and probability to have side effects if he will start with induction with sevoflurane and switch to desflurane, even for adult.
For what? For
adult patient. Adult.
No.
Is there side effects? No.
No, there is no side effects. Yeah, but why to start with sevoflurane? Yeah, because the thing is, and this is why I showed the study from Betty Mahmood from Scotland. If you start with sevoflurane, you are filling up the compartments with sevoflurane, and again, at the end, there is a slow elimination. So why to fill up the compartments with sevo initially when you have a much better drug with a lower solubility? So I do not recommend to combine these two things in adult patients. No, because we can induce adult patient with IV, and then stick on desflurane. I mean, in a very colloquial way, I always say, when do you get a headache? When you mix beer, wine, whiskey, and everything. Yeah. So stick on one and you will have a clear head. Yeah. And that's the point. So I'm not a fan of these kind of mixtures. I start with this and then do this. No, we induce with opioids, with propofol. This is our IV drugs we are using in my department. And then we go for volatile with desflurane.
Thank you very much. Another question on the effect on the myometrium in case of lower segment cesarean section under general anesthesia and the cervix flexibility.
I'm not aware of any negative effects in that term. When we do cesarean section, we also use desflurane, yeah. And we do not have any, or not to my knowledge, there is no negative effects shown on that. We all know that there is some dilative effects in some drugs, but since desflurane is a sympathomimetic drug, it doesn't widen vessels, and I'm not sure if it has a negative effect on the cervix as well. So I'm not aware of any negative effects. I will keep it like this, but this is a very specific question. Probably I have to look after. Yeah.
Okay, thank you, Professor.
We are using in my department. We are using for cesarean section. We are using desflurane as well.
Yeah, another question related to this patient. So, do the MAC value affecting the uterine contractility during the cesarean section?
Well, the thing is, I mean, we are, our gynecologists are doing the Masker-Fladach technique, which is pretty fast in opening the uterus, getting the baby out. And then we try to get to an end-tidal concentration once the birth is given and delivery is done, to get to 5%. And as to my knowledge, there is no negative effect, and I did not see any effects that there was postpartum bleeding or anything related to that. Yeah? But to be very honest, no matter if you're using sevoflurane or desflurane in that situation, once birth is given, and we do not apply desflurane because our gynecologists are pretty fast, yeah. Propofol lasts for around 6 to 7 minutes with an adequate depth of anesthesia, and within that period of time, birth is given, and after that, immediately we start with the influx of rule of 24, which takes us around 2 minutes. So usually there is no effect from my point of view on that. But I'm not aware of any evidence of any papers. I really have to look it up. I'm sorry. I do not know everything about desflurane. I know a lot, but not everything.
Thank you, Professor Poringer. Another question in cardiac surgery. Are there any predicted pharmacodynamic kinetic changes with hypothermia?
Now, I mean, we all know that in hypothermic situations that gases are better soluted, yeah. But as we all know, at the end of cardiac surgery, people are warmed up again, and these effects. This is like in a bottle of soda water or sparkling water, yeah. The warmer it gets, the less is soluted. So I'm very sure that during the hypothermic phase, there is a higher solubility of the gas, which is just a normal physical situation. But at the end, when people are getting warmer again, the releases, and again, due to the lower solubility, there is a more predictable release of desflurane. So there shouldn't be any impact in terms of prolonged elimination, because the warmer the body is, the less soluble. The colder the water is, the more solubility occurs in terms of oxygen, and the same situation is for volatile anesthetics.
Thank you. One of our attendees is asking you, Professor Pollinger, on the use of desflurane for thoracic surgery.
We are doing a lot of thoracic surgery here, one lung ventilation, and we use it according to the rule of 24, and there is no negative effects on that side. I know that some people might think that there is, the vasoconstriction or something, but we use it just like we use it for all other interventions and anesthesias, okay. Yeah, according to the rule of 24. So we place the double lumen tube, we check the position of the double lumen tube, and then we ventilate the patient according to the rule of 24. And when like there is like a resection of the trachea and there is an open system, of course we use TIVA. But if this is like a thoracoscopic operation, or if there is a resection of one lung that they are closing down, we use desflurane, and it's a stable and safe option to do.
Thank you, Professor Pollinger. So if we have to sum up, you are using desflurane for board patient groups.
Yes. So I mean, we are really using, no matter beginning from newborns to pediatric cases, to obese patients, to elderly, to smokers, COPD patients as well. Yeah. The thing for me is, when I look at like COPD patients or asthmatic patients, what is the biggest trouble for them? The biggest trouble for their vulnerable trachea is as a tube. Yeah. So this is why they sometimes postoperatively cough and cough and cough. Yeah. It's not the airway irritation due to desflurane. It's the irritation due to the tube. And this is why I try in those patients, whenever I can, I try to avoid the tube, because I put them in LMA, and we're using a Prosil, a second generation with a gastric access. Yeah. And then I try to bring them to spontaneous ventilation very, very early. Yeah. And if you're using desflurane on that level, there is no airway irritation because there is no tube in. Yeah. And we all know when we swallow some water into our trachea, how heavily we start coughing. And this is also when these patients with their vulnerable trachea get some foreign body placed in there.
Thank you, Professor Pollinger. Now, what's the place of desflurane in bariatric procedures for patients with obstructive sleep apnea, Professor Pollinger?
For me, it's the drug of choice. Yeah, I mean, the quality and the features provided. I think I clearly showed it out in my presentation. The low solubility, yeah, is the biggest advantage. So because you get rid of the drug, and we know that all these people like bariatric patients with obstetric sleep apnea. Yeah, I mean, what is the most important thing? That the structure, the functional structure of the pharynx is coming back soon, and there is no collapsibility. And this is why I try to avoid everything causing the collapsibility. This is why it is so important, especially in obese patients, to do neuromuscular monitoring. You know, that you know that residual neuromuscular block is also causing obstruction of the pharyngeal structures. Yeah, this is what we have to look for. Not only about the gas or the TIVA, we have to look about full recovery in terms of neuromuscular blocking drugs. Yeah, and whatever I can avoid by applying neuromuscular monitoring, by avoiding drugs like TIVA, like propofol, which is also causing a collapsibility of the upper airway. This is beneficial for the patient. And especially in bariatric patients, it is important that you get rid of the drug fast so that the patients get their natural integrity back again. Of course, I cannot solve the problem of obstetric sleep apnea by using Suprane, but I can avoid any negative side effects like hypoxemia, yeah, like depressed hypoxemic response, yeah, like impaired ventilation. And this is all beneficial for the patient.
Thank you, Professor Bollinger. Any recommendation when using LMA with desflurane?
Whenever a patient gets an LMA, we are using Desflurane, especially, you know, in urology, in gynecology, even in ENT. We are doing a lot of tonsillectomies, and all our tonsillectomies for pediatric cases with LMA and Desflurane. It's the perfect combination, because if you use Desflurane according to the rule of 24, there is no airway irritation. Yeah. And LMA is an excellent device. I mean, again, we have to consider, if we look in the evidence, that the incidence of aspiration is lower under LMA compared to the tube, even though there is the myth that there is a higher incidence of aspiration with the LMA. This is not true. Bernardini showed data from 60,000 patients, a meta-analysis of 60,000 patients published in the Anesthesia already 10 years ago, that there is a higher incidence in elective cases and in emergency cases for tubes compared to LMA. Yeah. Why? When do we aspirate? We aspirate at the laryngoscopic phase when we place the tube because of the stimulation of the laryngoscope, or at the end of anesthesia when there is still some residual paralysis and they take the tube out too early and people are regurgitating and are not able to protect their airway. And with LMA, you don't need a relaxant. And secondly, it's more gentle in the placement and at the end of anesthesia. People are waking up, opening the eyes. You tell them open your mouth, and you take it out. Nobody is coughing. So the LMA is a very, very gentle way of airway management.
Yeah, another question. How about the usage of desflurane while anesthetizing with the back mask ventilation for very short procedures?
With the back mask? Okay.
Yeah.
Okay. Yes, you can do it. You can do it, but you have to be sure. The thing is, there is some very interesting studies showing the quality of analgesia is also important to protect from airway reactions. So I once had a discussion with a colleague from Australia, and he said, whenever I do back mask ventilation with desflurane for short procedures, people are coughing. And I said, what kind of analgesia do you give? And he said, I just give paracetamol. And this is not working. You have to give a little bit of opioid. Yeah. So for a short procedure like a curettage in gynecology, I give 100 mg of fentanyl, because fentanyl kind of protects from airway reactions as well. Yeah. it provides from pain, and it provides also from airway reaction. And of course, Desflurane, you can use it with the bag mask. Yeah, no problem. But please do not say, because it's a short procedure, I do not provide proper analgesia. So in the combination, Desflurane, bag mask, and fentanyl or remifentanil or sufentanil, whatever you want, is a good option, and you can do it without any problems. But please do not provide bag mask ventilation with paracetamol only, because Desflurane per se is a little bit pungent, and even in low, and this causes coughing. Yeah. And then people are coughing, and it's the Desflurane. Yes, it's Desflurane, but it's the wrong combination. And there is nice studies already shown that there are airway reactions in the presence of a combination of Desflurane and paracetamol, or on diclofenac or things like that. Yeah.
Thank you very much. Another question. According to your experience, Professor Poringer, did you see a hemodynamic difference between the use of SIVO versus Desflurane?
Yeah, if you're using SIVO in high doses, you get a vasodilation and you get hypotension. This is what you don't see with Desflurane. Desflurane is a sympathomimetic drug. Yeah, it does not have any vasodilative effects. No vasodilative effects. And this is why in my institution, we are going for 5% end-tidal concentration, and we know at that level it remains. And if there is any changes in blood pressure during the anesthesia, blood pressure is going up or going down, there is no change in the depth of anesthesia, because depth of anesthesia is the green mark. It's gone. It's done. So if the blood pressure is going up or tachycardia occurs, it's pain. And if the pressure is going down, it's not vasodilative effects of Desflurane. No, it's volume or vasoconstrictive need. Yeah, and this is what we do. So the thing is, like in older days when we saw, okay, the blood pressure is going down, we were kind of reducing the depths of anesthesia, because all anesthetic gases, all other anesthetic gases are providing in high concentration a vasodilative effect. And then when you lower it, it probably goes down. This is not seen with Desflurane. So it's cardiovascular, very stable. Yeah. And there is no need to change any depths of anesthesia with Desflurane, because it won't have an effect on the vasal integrity.
Okay, thank you. I think it will be the last question, Professor Poringer. What about the relationship between Desflurane use and the greenhouse effect and air pollution?
Well, this is a big discussion at the moment. Yeah, very interesting. We have to consider that there is a greenhouse effect of volatile anesthetics. First of all, what is the greenhouse effect? The greenhouse effect is the absorption of infrared light, which is reflected from Earth and should go out into space again. Yeah, but because of the molecules in here, it is reflected back to Earth, and this is the greenhouse effect. So this is why the Earth is heating up. Yeah. First of all, we have to say that the greenhouse effect, 60% is done by water. Yeah, but we need water for living, for life. We cannot change this. And the rest of the 30% of other absorbing material inside the atmosphere is around 70% CO2. And the rest, and it's only 0.01% is anesthetic gases. So minimal. When we just, and I would like to put it in relation, because when we see the relation, it probably gets more clear. It's about 39 billion tons of CO2 we are producing every year. If we convert this into an Olympic swimming pool, 50-meter long, 20 meters wide, and 5 meters deep, this is the whole amount of CO2 we are producing every year worldwide. Yeah. And 0.01% of this is anesthetic gas, desflurane, 960 tons. So 39 billion tons of CO2 compared to not 1,000 tons, no, 960 tons of desflurane. And this represents 10 teaspoons, not soup spoons, teaspoons. Okay? This is the effect. The effect of desflurane is worse than the effect of SIBO. Why? Not because of the molecule, but the lifetime of the molecule. A SIBO molecule usually stays for 3 years in the atmosphere, and the lifetime of desflurane is around 11 years. So there is a kind of 3.5 times longer lifetime for desflurane compared to sevoflurane. But again, for me, and this is why people sometimes say, oh, we should use sevoflurane. No, I'm a doctor and I'm responsible for patient safety. And you know, as long as the relation is 10 teaspoons in an Olympic swimming pool annually, this is not my only effect I'm providing for. Yeah. The thing is, the relation just is not convincing me that I should leave a real, very, very safe and effective drug. We all do not discuss, and this is a very nice article in the recent Anesthesia Analgesia about the climate impact. We do not know what propofol does in water. Yeah, we do know that propofol is dangerous and harming fish in already very, very low concentrations. Yeah, so there is some impact of us on nature as medical doctors. And we have to be aware of that fact. I mean, we do not know what all the oncological drugs are doing in nature when people eliminate them through their urine and feces. And I do not want to inhibit oncological therapy because of those drugs. But I think, again, this is something that has been pushed by some people, not wanting to talk about the quality of a drug, just to talk about the greenhouse effect. And again, you know, I'm driving an electric car. I'm driving an electric car every day from home to my hospital and back home. Yeah. So I'm not the one who refuses to think about the environmental effects. But in terms of patient safety, I'm not willing to discuss patient safety. And especially if the effect is minimal in terms of the greenhouse effect compared to CO2 to methane. You know, I mean, methane is a gas produced by cows. The meat consumption is dramatically going up everywhere in the world. Yeah. Well, if we grow more cows, we produce more methane, much more methane than we use desflurane all over the world. And therefore, there is an effect. Yes, there is. But for me, in relation, this effect is minimum. And again, just another relation. If we consider the whole CO2 consumption or the whole CO2 production every year, this corresponds with the tower in New York, the Chrysler building in New York. Yeah, the Chrysler building in New York. And the desflurane impact is 1 millimeter. Okay? The Chrysler building is 448 meters high, and 1 millimeter is the effect of desflurane. And therefore, I have to say, there is an effect, no worries, but I think patient safety is the higher good for me in my daily clinical practice.
Thank you, Professor Pullinger. I think that tonight we covered several aspects and several points on the inhaled anesthesia use, and you showed the added value of the use of desflurane versus other inhaled anesthetics. So thank you, and special thanks to you, Professor Pullinger, to our attendees, and I hope to have you one more time for other points and other subjects. Thank you, and have a good night, Professor Pullinger. Bye-bye.
Thank you very much. It was a great pleasure for me. Thank you.
Yeah, thank you. Bye-bye.